Respected senior members in this August gathering, dear friends and colleagues, Neha, good morning, Namaste. I have been missing you. It's a long time we have not met. At the outset, I would like to put on record my sincere thanks to Professor Lee, to Dr. Jack, and other members of Golden Bridge Association who have given me this opportunity to interact with you. Today, I will be talking about tips for PCNL in anomalous kidneys. I have no disclosures to make, no conflict of interest. Other day, I was surfing the literature and I came across this study which was done in Zhejiang province of China, and it has been published in Italian Journal of Pediatrics, where they have seen the prevalence of congenital anomalies of the kidneys and urinary tract. It is called CACUT. They mentioned that 1.6 per thousand births have congenital anomalies, and ectopic kidneys are one of the commonest anomaly which can happen. One thing interesting which caught my attention was that there was a nearly twofold increase in the prevalence of CACUT from 2010 to 2016. In 6 years, the incidence of congenital anomalies of kidney is increasing. It's really surprising. And many of them are ectopic kidneys. Ectopic kidneys are thought to occur in about 1 out of 900 births, and almost 50% of these kidneys are at least partially blocked. And this partial blockage can impede the normal urinary drainage, and this promotes the urinary stasis and renal stone formation. And that is the reason many ectopic kidneys they present to us with urolithiasis. PCNL appears to be the most logical approach for treating stones in horseshoe kidneys and in anomalous kidneys, wherein stones are removed then and there, and there is no need to be dependent on clearing of stone fragments through a system where even free flow of fluid is compromised. So I believe PCNL is the best technique for treating stones in anomalous kidneys. So what we will be talking about is tips for PCNL in following ectopic kidney situations, like in horseshoe kidneys, in unascended kidneys, in crossed renal ectopia, in malrotated kidneys, and in pelvic kidneys. So let us start one by one. Regarding horseshoe kidneys, 1 out of 400 live births have horseshoe kidneys, and about every fifth horseshoe kidney, 20% of them, they have stones. When you are going to do a PCNL in a horseshoe kidney, upper pole access should be chosen because this gives you a very good approach and you can see everything in the pelvic calyceal system in horseshoe kidneys. It is also the easiest calyx to puncture, and since the horseshoe kidney which is coming above, which when it is ascending upwards, because of presence of isthmus, the ascent gets arrested because of superior mesenteric artery, and therefore horseshoe kidneys they do not ascend very high. They are always infracostal, and therefore punctures will rarely be supracostal if you make a puncture in upper calyx of the horseshoe kidney. So these are infracostal punctures and which give a very good access inside. That is why we should puncture the upper pole calyx. But once in a while, when maximum stone bulk is situated in the middle portion or in the lower calyces of the horseshoe kidney, you may puncture the middle calyx also. But lower calyceal puncture is very difficult in horseshoe kidneys. One more point when you are going to do PCNL in horseshoe kidney, you should remember is these are very much elongated kidneys. And when we are making an approach from posterior aspect, your instruments have to be really very long. You have to use a long nephroscope. only then your long amplat sheath. Only then you will be able to reach to the lower pole of the horseshoe kidneys. So before starting your PCNL in horseshoe, you should have long amplat sheaths, nephroscope, and longer instruments. Now, when you are coming from behind, it is very easy to puncture in a horseshoe kidney all the stones of the pelvis as well as stones located in the anterior portion or the anterior calyces of the lower pole. But accessing the posterior calyces of the lower pole is extremely difficult when you are coming from here. And therefore, if there is a stone in this area in the lower pole posterior calyx of the horseshoe kidney, you cannot approach through the nephroscope. You have to have a flexible nephroscope, only then you will be able to do this case successfully. So be ready with the flexible nephroscope also. Even flexible ureteroscope doesn't reach during RIRS to these posterior calyces which might be situated in the isthmus, and there is lot of angulation to reach up to this place. Neither they are accessible through a direct PCNL or via saline push technique. So there is no other way but to use flexible nephroscopes for stones situated in the lower posterior calyces of horseshoe kidney. Another point which you should remember is what is the relationship of colon in horseshoe kidneys. Since horseshoe kidneys are elevated like this, there is a large space created. Horseshoe kidney is here. There is a space created, and in 40% individuals, the colon will go retrorenal. In normal situations, it is only 2% in normally located kidneys. But in horseshoe kidneys, as this paper has shown, out of 12 patients, 5 had colon posterior to the kidney. So 40% of the colon in horseshoe kidney are posterior to the colon, posterior to the middle or lower portion of the kidney, and therefore you have to be extremely careful while puncturing these cases. Coming to the stones in unascended kidneys. These are very interesting cases. Unascended kidneys will be situated somewhere between L2 to sacral area, and you will always find at least one particular calyx which is popping up from this side, which God has made for making PCNL puncture. So like this case, when the kidney is unascended, the stone is situated at L5S1 level, there is one calyx available for puncturing, and you can put the patient in prone position, puncture this, access the pelvic ileal system, and you can easily do. Similarly, another case where the stone is situated at L5 level, but there is an inviting calyx which can be punctured in prone position, and prone PCNL is possible in most of the unascended kidneys which have come out of above the iliac crest level. Those can be, you can identify the calyx which can be approached and you can make the puncture. So any calyx in unascended kidneys which is popping up in this area, all this area, can easily be accessed in prone position and can be punctured. Prone position offers you such a wide area to access the unascended kidney. And in prone position, you have to be careful to remain lateral to the mid-scapular line from lower border of the 10th rib between 10th and 11th, between 11th and 12th rib. Supracostally, you can approach this area. Infracostally, you can approach any of this area right from transverse process of the vertebra up to the posterior axillary line, and you can approach a unascended kidney and make a puncture and get the stone out. Third situation is stones in crossed renal ectopia. I will give you two examples which are self-explanatory and give you tips. This case where the left kidney has come to the right, this is a crossed renal ectopia. He had a ureteric stone was removed and double J stent was indwelled. Next day morning, this patient was taken up for PCNL for this particular ectopic kidney. Now you can identify these are the two stones in the upper calyx. These are the stones in the infundibulum. These are stones in middle, lower calyces, and these are the pelvic stones. They can very well be explained over here. So in this case, you should be able to make, what I did was making a puncture in this area. That is what was done. Excess sheath was put here. All the stones in the infundibuli and the renal pelvis, they were very easily removed. Then the stones in the upper calyx, middle calyx, and lower calyx, they could be approached directly by needle punctures from the posterior aspect, and flushing was done with the saline push, and all the stones, they migrated towards the renal pelvis. So all the stones were removed by one track and three needle punctures. All the stones could be removed and antegrade stenting was done. Another example, it's a very, very interesting case. Now the right kidney has come to the left. This patient has got stones in the left kidney as well as in the right kidney, which has come to the left. And in this case, there was earlier, about 5 years ago, there was a ureteric stone, and there is a now huge residual hydronephrosis is there. So you can see in the upper calyx, in the upper kidney, left side, there is a stone, and in the lower portion, there are multiple stones in this particular kidney, and there is a hydronephrosis. So this case, I did both stones could be removed, both the kidneys could be approached through single incision. Both two ureteric catheters were passed. Patient was put in prone position. This was the single incision through which one implant sheath was passed in this area and normal left kidney was approached. Then this implant sheath was removed and this next time the puncture was made towards the unascended kidney, right-sided kidney which has come to the left, and all the stones were removed. So this is what, when the upper stone has been removed from the normal kidney, this was the implant sheath, antegrade stenting has been done, then contrast was injected, and the other kidney was identified. Now this implant sheath has been removed, and now through the same incision, puncture has been made into this kidney. The tract was dilated, stones were removed, and this is how, through single incision, both the kidneys were approached and the PCNL was done, and the patient was discharged next day morning without any problem. Fourth situation is when the stones are in malrotated kidneys. We come across such cases when the calyces are medially oriented. Now, how to puncture these calyces? It is very difficult to puncture these calyces and remove these stones. So, in such situation, what I have been telling is to do a percutaneous pylolithotomy. No need to puncture the calyces and the nephro and the kidney. You can directly puncture into the renal pelvis and remove the stone. And I have named this particular technique as percutaneous pylolithotomy. I had presented 18 such series of 18 such cases in World Congress of Endourology in Mumbai, and it was well appreciated. So this is also possible, direct puncture into the renal pelvis, but you have to be very careful. As soon as you puncture the renal pelvis, it immediately collapses. And once it gets collapsed, it is possible that your implant sheath will remain outside. So, and then getting entry into this collapse system becomes extremely difficult. So you should be careful, little more in, and you should not allow this to collapse and disappear from your sight. So this is how directly the pelvis was punctured and it was removed, and you can see the perirenal fat just outside this puncture, and the stones were removed through this particular implant sheath, and it was managed. Lastly, all of us are very familiar and use lap-guided PCNL for stones in the true pelvic and in inaccessible situations. If the stones are here or if the stone cannot be accessed through any calyx or direct puncture, we all know how to do a lap-guided PCNL. So that is what take-home messages will be. PCNL in prone position is logically the best and the safest treatment option for stones in anomalous ectopic kidneys. You must possess long implant sheath, long nephroscope, and flexible nephroscope for achieving complete clearance. And be extra vigilant and careful to avoid colonic injuries. Thank you very much for your kind attention. Thank you.